I'm Dr. Dan Cox, a professor of counseling psychology at the University of British Columbia, and welcome to Psychotherapy and Applied Psychology, where we explore practical insights with leading experts. Today, I am thrilled to welcome back Dr. Josie Geller, a world authority on treatment for eating disorders. In our conversation, we discuss integrating self compassion into recovery, barriers to self compassion, collaborative care versus directive care, evolving perspectives on eating disorders, and much more. Please feel free to leave a comment below, and if you enjoy this conversation, it would be much appreciated if you hit the like button and subscribe to the channel. This episode starts with Dr. Geller talking about integrating self-compassion into her practice and her research. Let's jump in.
Well, it was so cool for me when there was this explosion of self-compassion research that came out. It's now a couple of decades ago, but it seemed like self-compassion was was referring to how we relate to ourselves. So when we did this motivational work, we learned that so much of what enhanced motivation was the way that we connect with our patients. That having a more curious, open, non-judgmental stance where we have as our purpose in life to get the best possible understanding of what's going on, help the patient be more accepting of themselves. That those ingredients that were so important, where there wasn't like negative consequences to not being ready, where there was just an environment that was accepting of the individual that helped them to become ready. Self-compassion seemed to be a way of relating to oneself that uses those same ingredients. Rather than take out a baseball bat when I notice that I'm doing something that isn't the way I want it to be, it's instead being open and curious and interested to understand what's going on better. Recognizing that I'm not the only one who makes mistakes or who has challenges in life, and having an aspiration to be kind, to be motivated to reduce distress and suffering in myself. So the self-compassion research started out with someone called Kristin Neff, who kind of exploded on the scene with this model that self-compassion is being attentive to our internal experiences, knowing that we're not alone when we have hardship, and being motivated to be kind to ourselves. But I think from a clinical perspective, the model that fits a little bit better with our patients, I mean, they both fit really well, is Paul Gilbert talks about compassion as a sensitivity to suffering with a motivation, and he really emphasizes the motivational component to relieve suffering. And so if we think about self-compassion, it would be having a sensitivity, which is similar to Kristin Neff's definition of mindfulness. So just being tuned in to difficulties that I'm experiencing within myself, and then having motivation to try to reduce that suffering. And so when we first started to look at self-compassion in people who have eating disorders, we were amazed to discover that it's almost like having low self-compassion was synonymous with having all the symptoms of an eating disorder, having high drive for thinness, and having more episodes of binging and restrictive eating. That it was just almost like it would be impossible to have an eating disorder and to have high self-compassion from our original data. But more interestingly, we discovered, because in our program we're always doing continuous quality improvement research, so we're always looking at what do people look like when they begin treatment, post-treatment, and at follow-up. Up until for 20 years, there was only one variable that predicted how much people benefit from treatment, and that was readiness. And it's a consistent finding. It keeps coming every couple of years when we do this research. And for the first time, we looked at people's self-compassion, and we also looked at, there's something called fears of compassion or barriers to self-compassion. And we looked at people's barriers to self-compassion as well at baseline and throughout treatment. And what we found, lo and behold, was for the first time we had a second variable that predicted outcome in our treatment programs, and that was having barriers to self-compassion. In other words, for people who are saying, for some reason, I think self-compassion is not a good idea for me, those people benefited less from our treatment. So that got us really interested, and we started out by just trying to understand, well, what are the barriers that people have to self-compassion for people who have eating disorders? And we found that there were two types of barriers. The first one was, we call it meeting standards. It's having the belief that if I practice self-compassion, if I'm nice to myself in times of difficulty, if I'm motivated to be nice to myself, then that's like letting myself off the hook, and I'm going to become a slob and fat and lazy, and I'm never going to accomplish anything. And the people who love me based on my accomplishments won't love me anymore. So why would I practice self-compassion? Because I'm going to lose all the things that are important to me. Turns out that there's all kinds of data that refutes that, and that shows that that's not the case, that actually people who practice self-compassion achieve just as much as people who don't. In fact, they achieve more. It's just that rather than have their entire focus on achieving a goal, and feeling really hard on themselves the whole time while they're working towards the goal, and then experiencing, satisfaction for about 45 seconds after they get the goal, and then they get another goal, and then they're hard on themselves till they get the next goal. People who practice self-compassion actually are taking pleasure and delight and joy in the process of learning or pushing themselves or doing whatever steps that are involved in working towards the goal, that there's an intrinsic enjoyment of the process. So they are achieving, they just aren't having their well-being contingent upon achieving the goal. It's actually the entire process that is enjoyable for them, or more enjoyable for them. So that's the first barrier, is meeting standards. The other barrier we called emotional vulnerability. And this barrier is having, it's much more linked in feelings of vulnerability about if I was kind to myself, would it put me in touch with emotions that I wouldn't know how to cope with? Would it, or maybe because I feel like I actually don't deserve anyone to be kind to myself, but that's so unfamiliar. I don't, maybe it's something that other people could have, but I don't feel like I should have it for myself. Or for some individuals, and this was really common, I don't even know what you're talking about. It's so foreign to me to be kind to myself. I'm so used to being critical that that's a totally foreign concept to me. And we found that people who have the meeting standards barriers, that was more associated with readiness early on in treatment, and the emotional vulnerability barriers were more associated with the hard work that we do when we're really exploring the function of the eating disorder, trauma, and figuring out, how do I need to care for myself so that I don't need the eating disorder so much.
It seems like there's some parallels here between that, those barriers to self-compassion and the function of the eating disorder behavior.
Very much so. In fact, I think they're very linked. In many cases, as I understand the function of my eating disorder, it feels a little bit less scary for me to, to do the work of learning alternate ways of coping with difficult feelings and difficult experiences that I've had.
So what are some ways that y'all have found that are helpful for reducing these barriers?
Yeah, so that was really the topic of our last set of projects, was how do we reduce barriers to self-compassion when we know that they're linked to not benefiting from treatment when I have those barriers. So we just actually completed a couple of qualitative studies. One was in people who had recovered from an eating disorder. So they had or were pretty far along in recovery, and we basically asked them, what did anybody do? They were very clear that one of, we have an experience of care survey that patients complete at the end of treatment. And we found that they were consistently saying that one of the things that helped them the most in their recovery was developing self-compassion, that it was one of the most profound parts of their treatment experience. And when we asked them, what did anybody do that helped you overcome your barriers? I could summarize that entire project down with one word: validation. So we actually wrote a paper called "The Power of Validation," and it's one of the most profound, simple but complex concepts that has come up in this area. So basically, they said there were 4 levels of validation, and when people, whether it was clinicians or family members or people in my life, offered me these levels of validation, I slowly was able to overcome barriers to self-compassion and to become more compassionate myself. So the first level was two things. It was basically um, it seems so simple, and I'm sure your students who are working in therapy would know that this is critical. But basically, making time and space for me. So really showing me with words and body language that you're not just asking a question so that you're ready to ask the next question, but that you're really listening to what I'm saying, and offering a compassionate perspective. So whatever it is that I say, if I tell you that I'm struggling with something, rather than having a neutral or possibly slightly critical way of looking at what I'm saying, that you're seeing that whatever I'm doing, it happened for a reason, and it's my best attempt at meeting a need that I have. And so when people in their life were able to do those two things, make time and space for me and offer a compassionate perspective, then the impact that it had on them was trust. That was the first building block for overcoming barriers to self-compassion, that I feel like I can trust this situation to really be open and talk about what's going on for me. The next level had everything to do with readiness. It's basically someone who took the time to truly understand and recognize my treatment needs. So they weren't saying, okay, you have this level of severity, you need this treatment. They were actually taking more time to understand, what's my level of readiness? What would it be like for me to make changes? What's happened for me in the past when I've made changes? What are my wishes right now? So they weren't pushing me before I was ready, and they also weren't not noticing that I'm ready and this is the time to give me some tools or some treatment options that I'm ready to benefit from it. So when people took the time to understand and recognize my treatment needs, to offer a menu of options like in the stated, where we have a little home for each of the different combinations, the impact was cared for. So we get trust from the first level, cared for from understanding, recognizing my treatment needs. Then the next level after that was, very often people would start to make changes, and people in their lives would say, great, they're eating more, they're not binging and purging so much, we don't need to worry about them, we don't need to be checking in with them. But very often they would say that at that point, they were in more distress than they had ever been, because now they aren't using their eating disorder, and they felt even more vulnerable. But people were kind of saying, great, we don't need to worry about them because their behaviors are showing that they're in recovery. And so what they said that they really benefited from there was someone recognizing, wow, I can see how hard you're working. I'm really, noticing and impressed with the courage that you're showing right now. And I know that this must be pretty tough. Tell me about that, and giving them an opportunity to talk about the challenges that they're facing, and pointing out their strengths, saying, I've seen you use these strengths in other circumstances, and I can see those potentially helping you right now. Basically, just noticing how tough and hard this is, and recognizing their strengths. And when people did that level of validation, that made them feel empowered. So we got trust, cared for, empowered. And then on the last level of validation, which was totally unexpected, we called it walking the runway finding. And those were words that one of the patients actually gave us. And it's basically the patient saying, don't tell me to practice self-compassion, just like you're shoving a meal plan at me, telling me I should do self-compassion. Show me what it looks like on you. Let me look at how the fabric flows as you walk down the runway when you're wearing self-compassion. Show me that sometimes you make mistakes, and that you practice self-compassion to not beat up on yourself, and to be understanding and kind to yourself and make yourself feel better. So they don't want to know our whole life story, but they want to know that we're also human, that we also have challenges, and that we also use these techniques. And when we rock with the runway, the impact that it had on them was inspired. So this is kind of like a crib sheet of what the environmental components are that help people to overcome barriers to self-compassion when they're in an environment of validation. And this is probably the one paper that we get the most attention from. And when I talk about it with our patients, that they're saying, can you give that paper to, my parents or, my loved ones, that it's something that they really resonate with and feel like it's an important part of their journey.
And so do you think that this process is somewhat sequential?
I described it in that way, and I think that people go in and out of the different levels. But generally speaking, at the very beginning, we really need to build trust and we really need to have it cared for. So I think those are more early on. And I think the empowering is more for once people are actively working on change. And then the inspired one actually occurs across levels. I think it's really useful for them to see that, I'm not some, person way up here telling you what to do. But, I can relate. We're co-humans, and everybody has challenges, and we're the same in that regard. And I'm not kind of in a totally different, perfect life situation that is so disconnected from where you're at.
So one of the things that I've always been unclear about is like how, because from what I understand, and tell me if I'm wrong, still a certain part of a lot of programs is some sort of ensuring eating a certain number of calories and that sort of thing. And that's always felt like what you're like, there seems like a tension there. Yeah. How do you think about, but obviously, you all have spent countless hours and lots of time to think about how to do this and deal with that tension. I'm just super curious about it.
Yeah, well, it's all about getting buy-in. That being interested in making dietary changes is something that I've decided will be beneficial to me. And when we have the readiness piece, when they're saying, "Yeah, I can see that it's getting in the way of things that are really important to me." So now that I'm not being so hard on myself, that that I have this eating disorder, and I understand that it's been my way of coping with trauma or difficult experiences, and now I feel a little bit better able to cope with those things. I can see that it's causing difficulties for me to be, so focused on food or physically unable to do things. So I really need the support to work on making dietary changes as well. And very often, of course, there's cognitive impairment when I haven't been eating enough. And so there's a combination of needing some nourishment while I'm doing this work, so that I'm in a place that I can make use of treatment down the line. But it does definitely require a decision on the part of the individual that the life that I have now isn't the one that I want moving forward, that I want there to be some change and an openness to receiving support to make those changes.
So it comes back to that story that you told a bit ago. I think you said, I don't remember if you said something like eating your way into the closet, right? Eating
Yeah.
your way, like, these are the things I love doing. In
Yeah.
order for me to be able to do them in a way that I can do them how I want to do them, I
Yeah.
have to eat certain types of stuff just to function, right? And so
Exactly.
it's working probably very slowly with a client to figure what that looks like for them.
Yeah, and that really is, I think, what happens in our discovery program. So our residential treatment, that program, it's such a beautiful self compassion or a compassionate environment where people are given opportunities to, finally unpack some of the difficulties and challenges that they've faced and have new ways of coping and different ways of managing emotions and the challenges that they have in their life. And the cost of admission for being in that program is to be normalizing one's eating, and to be accepting the support to provide some structure around mealtime. And so most people who come into the program have mixed feelings about that aspect of treatment. They know it's going to be challenging, but they also know that they're going to have access to, opportunities to work on their skills and compassion and be able to have a different kind of life. And so, and support to make the eating changes as well. So, it's like getting people to a level of readiness that that doesn't feel like a completely overwhelming proposition, where they know that they're going to be receiving supports and it's worth it for them to start dipping their toe. And very often we also describe it not as you're committing to this for ever and ever. We're describing it as what have you got to lose by experimenting, by trying this out, and you can always go back to where things were before, but this at least gives you an opportunity to experience something differently.
So what we've mostly been talking about is this. In your writing, a lot of times you talk about collaborative care and how I've come to understand it. And then listening to you today, a lot of what you're talking about is you're really making it clear that this is a very collaborative process, and that's sort of the way to go. And in your writing, you compare it versus what is more directive care.
Yeah.
You did some work, which I thought was, well, on therapist, or maybe I should say clinician, I'm not sure, but helping professional compassion as it relates to them, the practitioner using more collaborative versus more directive care.
Yeah.
I was wondering if you could talk about that a little bit.
Yeah. Well, just that it turns, in terms of motivation and self-compassion, we've discovered that our patients benefit enormously from a collaborative environment versus a directive environment. And we just got interested in this because it was so clear to our patients that when we were more directive, they felt like treatment was less acceptable. They were more likely to drop out. There were that it was a it was setting up the very things that we wanted the opposite thing to happen. We wanted them to be feeling more motivated and more accepting, that when we were overly directive and not including their needs, that treatment was less successful. And so we just got interested in this, and we ended up making it was actually our patients who gave us the idea that it's not just what we say, but how we say it that most matters. And we developed some measures that would operationalize using a more collaborative versus directive stance. And basically, the ingredients of collaborative care, as we define it, had these 4 components, like basically not making any assumptions about the patient, that about their readiness or about what they want to do. Having an aspiration to help with what matters to the client, so not just wanting them to do what I want them to do. Having a really clear framework. And this was also something that kind of got some pushback at some point. We called it a non-negotiable framework. So basically, what are the contingencies, the conditions that we think are most likely to promote health and positive behavior change, and that when we had non-negotiables that were implemented in a certain way, that is, we had lots of conversations about them, we created them very thoughtfully, so there was a good rationale for whatever we did. We explained the rationale to the patients. We include patient input in the non-negotiable framework. We were consistent about implementing them, so we didn't do it one way with one patient and a different way with another patient, or one way at one point in time and a different way at another point in time. That just made everybody crazy. And where we didn't have surprises. People were always given lots of advance warning about what the non-negotiables were, so that there were no surprises, which tend to increase anxiety. So when we had a clear framework that had those non-negotiable treatment components, that also made patients feel safe and more likely to experience us as being collaborative. So the difference also between collaborative and directive is that when we're being directive, it is experienced as we're like the therapist trying to make something happen. We have an agenda that we want the patient to do, and they're kind of small and we're kind of big up here. But in a collaborative model, we're the same size as the patient, and what's up here is the non-negotiable framework that we've actually already agreed upon and used a really collaborative process, inclusive process, to determine what they are. And our job is just to help the patient make the best decision for themselves, given the alternatives that exist in the framework. And so we're really standing side by side with the patient. And we do some really fun exercises with clinicians where we experiment what happens if we try and make something happen this way versus this way. And where the client has an opportunity to basically talk through, okay, well, let's say I'm on the inpatient unit and lunchtime has come and I don't want to eat my lunch. We could say, well, you have to eat your lunch. You committed to that. Or we could say, well, what was the agreement that you came to when you came on the unit? And when they say, well, I was have to eat my lunch, or I would have to replace with Entre. Okay, well, sounds like you're not really interested in doing the lunch. How do you feel about replacing with a supplement? Well, I don't really want to do that either. Okay, tell me more about that. We talk about And ultimately, we say, how can I help you make the best decision, given the circumstances that you're in right now? And so it's a very, it's impossible to get into a fight with this person. We already have a shared agreement about what the conditions are, and I'm just recognizing what would it be like. Let's say it comes down to, well, if I don't replace, then I might be asked to leave because I'm medically stable right now, so I might be asked to leave program. And so then it wouldn't be, well, then you better eat it. It would be like, okay, well, what would it be like for you now to leave program? And they might say something like, well, it would be a relief in some ways, but, or sorry, yeah, it would be a relief in some ways because it's hard being here. But, it's also been kind of nice to have a break from my life and to get some, healthy input. And, I feel physically better since I've been here. And, so actually it would be difficult in some ways to go home too. And then my role as the clinician, rather than say, therefore you should do it, it would be, wow, I can see there's some pros and cons to having this lunch and there's some pros and cons to leaving. How can I help you make the best decision for yourself? And that process of standing side by side and helping them to make the best decisions about their care, rather than being in this place of authority where I'm trying to make them do something, is experienced by patients as collaborative and much more conducive to both to readiness and to self-compassion. So we're basically looking at how to help all of us to create a climate where we're using that more collaborative approach.
And you did some work looking at therapist compassion, self-compassion and other compassion, and its association with their use of more collaborative versus directive care, right?
Exactly. Yeah. Yeah. So it turns out that as clinicians are more self-compassionate themselves and have more compassion for their patients, they're more likely to use a collaborative stance, which we know to be helpful. And we're doing a similar project right now in family members where we're looking to see what are the factors that support family members in maintaining a collaborative stance.
And so when I read that paper, I really liked it. One of the things that sort of stood out to me is okay, what are the characteristics, and these aren't necessarily permanent characteristics, but what are the characteristics of the helpers that are sort of facilitating or inhibiting their use of collaboration? And what I really liked about it is oftentimes we talk about approaches as like we're using a collaborative care approach,
Yeah.
or, and it's very much like this, am I using this model, this approach, or am I not using this model or approach? And the way that I read what the work that you all did was more like, it's not that simple as just like, this is a kind of, quote unquote, collaborative program, because you can be in a quote unquote collaborative program and really not be acting very collaborative.
Exactly.
Or I would imagine there's lots of people in very sort of top-down directive programs, that the administrators of those programs would describe them in those sorts of, they might not use that language, but that would be what they would be describing. And I'm sure that there are extremely collaborative helpers in that program.
Yeah.
So just sort of like trying to understand these as more, what are the characteristics of the helpers that might lead them to be more collaborative or not. And then that, to me, sort of also then says, well, if we can figure out what those are, then maybe we can turn those knobs or target those knobs to help them to be more collaborative.
Exactly. Yeah. That it's not so straightforward. It's not just parroting some words. It's actually the spirit of the interaction. And that's what we're, if you were to think of my entire program of research, I think at the end of the day, that's really what I care about the most is what is the aspiration that I have? What am I actually trying to have occur in my relationship with my patient, or maybe even my relationship with my colleagues? And it makes me think a little bit of this other project that we did also with regard to learning about validation and the conditions that promote self-compassion in family members of adults with eating disorders. It's the same thing where we ended up coming up with this conceptualization of family members typically start their journey with their loved one of adults with eating disorders anyhow, probably with kids too, to just fix the eating disorder, like just fix it, make it go away, which is kind of like us, just eat the meal plan, just, go to full recovery. And that family members over time of adults with eating disorders reached a different aspiration, which was much more therapeutic and paradoxically helpful in their loved one's recovery, which was to have an aspiration to have an unrelenting connection with their loved one. So
Wow.
it's starting from fix the problem and it's ending with I want an unrelenting connection with my loved one no matter what. And that's a very different, I'd be doing different things to achieve those two goals. Fix it is like I might be being critical and judging you and telling you to eat things or just really encouraging you to eat things. Whereas in the aspiration to have an unrelenting connection, there would be taking a bit of a step back and maybe learning that I need to manage my own reactions and accept that maybe this isn't going to go exactly along the way that I would wish for it to go. That's one step. There's actually 3 processes that connect fix it to unrelenting connection. So the first is just like having some support for myself and being able to accept and manage and change my expectations. Then the second part was recognizing that my loved one has some boundaries that I need to respect, and also recognizing that I have some boundaries that I need to respect. So sometimes there was a little bit of a over involvement, and seeing that there's some benefit in letting my loved one do some things, and also seeing some benefit that I need to look after myself too. So I need to manage my reactions. I need to respect boundaries. And then the last piece that connects fix it to unrelenting connection is learning and practicing validation. So coming to understand that, being a really good listener, offering a compassionate perspective, not pushing them before they're ready, saying empowering things to them, or recognizing how hard they're working when they're doing hard things, and walking the runway if possible. All of those things are helpful in fostering a better connection with my loved one, and ultimately letting them know that no matter what happens with your eating disorder, I'm going to be by your side. And paradoxically, when we say that, the eating disorder gets better. So it's another one of those paradoxes, like we were talking about in the beginning.
I think it's a beautiful phrase, having an, because I'm thinking about it sort of as a parent, and I'm thinking like, because you're always looking for these sort of North Star ways of being a parent, and but
Sure,
in a way that is like, and what a lovely kind of phrase for that, right? Having an unrelenting connection with my loved one, right? With your son, your daughter, whatever. And that's like that. Yeah, that's really lovely. So to get it down to such a pithy but clear framework.
Yeah,
really
it probably
nice.
applies to all kinds of parenting situations and life situations. At the end of the day, am I trying to like get what I want, or am I recognizing that the most important thing here is our connections with one another? And that at the end of the day, that's what we're all going to care about the most.
Right, and I think that it's with loved ones, with folks with eating disorders, that they're, even though they might be more wanting to problem solve and directive and get a lot of that is born out of love and caring and
Of course,
whatever. And then like, okay, so how can we take that energy, that motivation, and sort of shift it in a way that,
exactly.
yeah.
And a big part of what supports those 3 things is the parents and everybody receiving support and getting some care for themselves. Like we need to have our own well filled up in order to offer our best selves and to be able to keep our eye on the ball, that at the end of the day, the connection is what matters the most.
Right. So being mindful of the time. So what I was going to ask you, and it's totally up to you if you want to go there or not, is sort of if you think we're at a good place regarding the DSM-5 eating disorder criteria. I always like to just get a sense of where people who spend a lot of time thinking about these things, where they sort of see the oftentimes potential limitations in the DSM.
Yeah. I mean, I think a lot of people are increasingly moving to, sort of trans-diagnostic approach to seeing that we do have these kind of arbitrary cutoff criteria for what determines an eating disorder. We've changed a lot of them. We've taken things like menstruation out because that never applied to males in the first place. And, I think increasingly we're just looking at how much is someone's life impaired by what's going on with their eating. I'd say one of the biggest issues that's facing us right now is that up until now, the treatment centers, tertiary treatment care in British Columbia, anyhow, has focused on anorexia and bulimia. And there's always been a giant gap for people who have binge eating disorder. So very often their lives are just as impaired, but they haven't had access to tertiary level care. And so that's something that's being considered moving forward. And then, we've always had a catch-all diagnostic criteria of other OSFED, other specified feeding and eating disorders, where because they don't meet the strict criteria of anorexia or bulimia, but still could have tremendous life impairment, that it's still important for us to have treatment that meets their needs, and that would honestly look the same. We're not doing anything different because they don't meet all of the criteria.
Got it. So are there one or two resources that you want to, I always like to ask so I can include stuff in the show notes for people who want to learn more specifically about your work or other things that you want to point people to?
I think that for people who just want some quick and dirty techniques or things that would be useful, I actually think that our most recent publications on validation could be really helpful. And depending on how nerdy you want them to be, we have one. We have like a journal article version of power validation. We also have a lay person's version that I can send both of those to you, Dan.
That'd be
that
great.
People might want to look at. You can also just look me up on the Center for Advancing Health, and most of my publications are there.
Great. I will link to those. Great. This has been fantastic. Thanks so much for watching. If you found it helpful, please like the video and subscribe to the channel. I'll see you in the next video where we continue exploring the science of psychotherapy and applied psychology.